My name is Craig Mitten. I'm a professor in the School of Population and Public Health at UBC and also a scientist at the Centre for Clinical Epidemiology and Evaluation at the Vancouver Coastal Research Health Institute. As a health economist, I spend most of my time dealing with how decision makers go about making difficult choices about what to fund and what not to fund. It's important to provide decision makers with the best tools available for them to make those difficult decisions. It's critical to think about resource allocation because we have a limited pot of resources. Even within a resource-rich country like Canada, we have to make choices amongst the competing claims on those limited resources. There's many different ways to look at resources in the health system, and whether we're talking about money, people, or time, in all of those cases we're talking about having scarcity of resources or a limited amount of resources to go around. The amount we spend on healthcare is the highest single cost in the provincial budget. Every province spends about 45% of their provincial budget on healthcare, which means that everything else we have 55% to spend on. So education, post-secondary education, roads, bridges. So we need to think through quite carefully then, not only how much do we spend on healthcare, but how best can we spend those resources within healthcare. Within the health authority context, we have managers who are responsible for budgets, and those managers have to make the specific decisions about what services to fund and what not to fund. So what we as health economists like to do, and what we contribute to the discussion of resource allocation, is to provide methods and tools to those managers within the health system in order to improve their ways of decision making, so that when they're having to make a decision about one drug versus another, or whether patients should be seen in a hospital setting versus an outpatient clinic setting, we will provide those managers with the tools to be able to compare costs and benefits of the different options and allowing managers to make better decisions for those limited resources available. The idea behind thinking through costs and benefits is really one of a notion of value. So many clinicians will actually approach the problem of resource allocation and say, we need to do the thing that will provide the best clinical benefit. The highest clinical effectiveness is what we need to strive for. And you'll have accountants on the other side who are very interested in minimizing cost. It should all be about how we can live within our means and simply provide the cheapest option. Whereas the economic way of thinking is to bring costs and benefits together. And in that, we're interested in the concept of value. So how do we get the greatest value or the greatest return on the limited resources available so that we as taxpayers are assured that we're getting the most benefit for those resources available. So when we think about health economic tools that can inform decision makers about how best to spend the limited resources within the health system, instead of going behind closed doors and making decisions that are not, the process isn't known, the decisions might be held close to their vest, we're saying we need to be more open, we need to be more transparent. And what that transparency then leads us to is greater accountability, in addition, greater defensibility. So when a member of the legislature comes to a decision maker and says, you know what, why did we make those decisions to reduce services in one area in order to reinvest and increase services in another area? That decision maker can say, well, this was the right decision. We weighed out the costs and benefits of the alternative options, and we have a process or a framework of decision making to stand on. So one key area for the public to be involved in decision making is around obtaining the values of the public that would underpin decisions for resource allocation. Another area is to have members of the public sit directly on decision making committees. And in some of the work that I've done in Ontario and across the country, we've actually had members of the public sit on priority setting committees alongside of the decision makers, whereby the members of the public have been in real-world context, asked for their opinions, their advice, their feedback, their values perspective on a given set of trade-off decisions that have to be made. And that's a really exciting place to see decision makers and the members of the public interact and grapple with resource allocation challenges.
I'm Barbara Kaminsky. I'm the CEO of the Canadian Cancer Society in British Columbia and the Yukon. Many of us have personal stories, people that were close to them that actually faced this very situation. I had a very dear friend who eventually died of colorectal cancer, but she was on the leading edge of being able to use a number of experimental drugs. So she actually endured, I say endured, 2 extra years. She wanted more time with her new husband. Well, I remember her near her death. She said, you know, Barbara, if I had to do this again, I don't know if I'd do it because, yes, I had 2 more years with the love of my life, but I spent most of those 2 years puking in the toilet. So if she had it to do again, she wondered. When people hear that in the next 15 years there's going to be a 40% increase in the number of new cancer cases, some people actually sort of freak out. They think, oh my God, is there like some sort of epidemic that arises in the future? Well, no, basically what this is extending current population projections onto current cancer rates. So the rates would be relatively stable with this 40% increase, but because of the growth, and most specifically the aging of the population, our risk does increase and our numbers increase. It's not getting easier in terms of fiscal challenges. Governments don't want to keep increasing taxes, and neither do we as taxpayers. And when we look at those projections for the future in terms of new cancer cases going forward, we have a chance now to make things better. I'm not saying it's going to be painless, the change, but if we don't start now, it's going to only get more challenging into the future. There are new drugs that are being discovered and frankly promoted quite strongly by drug companies. And a lot of patients, they're very, well, frankly, in some cases they're quite desperate because currently what's available by way of therapy isn't necessarily going to help them. So we want to be advocates in the Canadian Cancer Society, but it's important that we be evidence-based. We need to make sure that if we're asking for a particular drug to be approved, that we can, with confidence, say that it's worthwhile to do this. So the question is, for the increased cost, is it worth it at the margin? Is it going to give you a longer life? Is it going to give you better quality of life? That's the dilemma. Now, people may have the impression that it comes down to some sort of magic mathematical formula. You plug these numbers in, you know, the black box does its magic and out spits the answer. It's not that way. And can you imagine the spot to be put in if you're the Minister of Health or if you're in charge of a cancer treatment facility and you're the one that has to make this decision? It's very, very heavy in terms of what you have to do. And it's not just about calculating and evidence, it's about the human feeling behind this as well. So once you understand the dilemma that these decision makers have on their hands, you probably wouldn't want their jobs. There's always a problem when you have people that are immediately suffering in front of you, especially if you're actually trying to treat that patient. It's very real, and you'd want to do anything you can, even if you think it's almost hopeless. So that human dimension will always be there, and we want it to be there. We don't want this to be run by computers. But that said, if you do that, are you depriving someone else of something that would have been more effective? It all comes down to how you choose to allocate these scarce resources. And there's opportunity costs. If you spend money on drugs that have marginal utility, marginal effectiveness, it means you can't spend money somewhere else that could ultimately have more impact. So we want everything to be based on the best research possible. But certainly, every single year when we look at the submissions that come in, people asking for grants for the wonderful research they want to do, we never have enough money to fund all of those that meet our scientific criteria. So at the margin, would that money be better used for another drug, or would it be better used for more research? Another thing that people need to struggle with is prevention. About half of cancers could be prevented. Okay, so even if we had 100% survival rates for cancer patients, and even at good quality of life afterwards, wouldn't we all prefer never to get cancer to begin with? Then there's other things that people need to bear in mind. There's a lot of supports that people need when they go through cancer, whether it's emotional support, information, etc. Who's going to fund that? And then unfortunately for people who are not going to be successful at the end of their cancer journey, have we done everything we can in terms of palliative care, end of life care? Well, no, we haven't. So all of these choices need to be made. If you spend money somewhere, it's at the sacrifice of something else that maybe in the bigger picture would be more intelligent spending.
My name's Nadine Carone. I'm a general oncology surgeon up in Prince George, British Columbia. On a day-to-day basis, I operate on patients with various types of cancers. I see patients, therefore, in the clinic. I do cancer research, focusing more on access and utilization, and particularly in the area of rural, remote, northern, and Indigenous cancer care services. And I teach. The type of research I look at is really how do we get individuals to cancer services? How do we help people so that they never need those cancer services? How do we help people understand why these services are there and when they can use them, how they should use them? And so really sort of the why upstream. I think there's two fundamental elements of cancer care that if I were to change today, and I could, I would. And those are access and utilization to the services that are available. And those are very related, but different. Access to care is basically when someone needs the care, wants the care, decides to use the care, and the system lets them down. And the system lets them down either because there's the wait times we always hear about, there's no access in their community, and then there's the barriers to it. They would if they could, but financially they can't, socially they can't, and even culturally. But utilization is when, for some reason, our system isn't safe enough, or someone doesn't understand it, or there's misconceptions, where in essence, it's right there, but for some reason, there's something in the system that makes it so that an individual doesn't utilize it. What we're really realizing more and more about cancer care, even in the healthcare system, although I think we were slow to pick it up, is that, we have a patient that we're seeing in the office or that we're bringing to the operating room, but there's family members in that office with them. There's family members waiting after the operating room that you go and see and tell them how they are. These people come from communities. And these communities are wondering, how are their loved ones going to do? How's their neighbor going to do? How's their, especially in the rural communities, how's their only banker, their only accountant, their only this, their only that? How are they doing? And we're starting to realize that every diagnosis touches a very, very broad group of people. And if we start to recognize that, we realize that those are the voices that should be at the table when we're talking about cancer care in general. There's barriers to cancer care everywhere. But I think that those in the North have an element of uniqueness that really need to be addressed, considered, explored, researched, and most of all, just simply understood. There's other differences besides geography in rural and remote areas. There's the financial consequences of having to travel further for longer and be away for longer. There's the social consequences, often because you're in a smaller community. And then there's the cultural differences that we can't afford to forget in this whole equation, and realize that we need to address those in a sensitive way. And I don't think we do that as well as we should. I remember the first breast cancer patient that I ever met. It was an incredible eye-opener to me. So I started going over with her with the options for surgery. I had this discussion with her, very smart lady. She was following this, she understood it. And then all of a sudden she started asking me questions. She asked, if I choose radiation, where is that done? it was Vancouver or Kelowna were the two nearest sites. So 8-hour drive or a 10-hour drive or the cost of flights, and that she'd be there for about a month. We talked about breast reconstruction. There was no plastic surgeon in the entire Northern Health Authority. She would have to go to Vancouver for that. And ultimately, why did I give her these options? I felt that fundamentally, she deserved to have the same options as the patient that I had talked to 4 months earlier when I was a resident in Vancouver. All of a sudden, it was a big eye-opener to me. Being in northern British Columbia, it wasn't the same as being in Vancouver. It wasn't the same as being down south. The options in a textbook, those weren't available to people in the north. Our voices need to be heard as well. And sometimes when we talk about who's making those decisions, very difficult and complex decisions as they are, we have to make sure that that difference is not shied away from, and those perspectives are heard when we're talking about any resource utilization in the context of cancer care.
My name is Janessa Laskin. I'm a medical oncologist at the Cancer Agency in Vancouver. And what we're going to talk about today is about accessing drugs for patients with cancers and how we think about that as physicians. So I'm a medical oncologist, which means that I'm a chemotherapy specialist. So when patients come to me with cancer, I think about how chemotherapy can and maybe cannot help them in their journey through the whole cancer process. And so part of my decision making is very individualistic, and a lot of it depends on what kind of chemotherapy treatments are available at any given day, any given year, and so on. So these things change quite a bit. Why it's important is, of course, because chemotherapy is the mainstay of cancer treatment. We use chemotherapy, radiation, and surgery. Those are really the only cancer treatments that there are. And so we really try to save people's lives. We try to treat people. Mostly what we try to do is give people some quality of life while they're dealing with this disease. People do think about cancer as one disease, but that's an old way of thinking about cancer. I think the general process of your own body's cells going wrong is common to all cancers. But as each individual is different, the kind of ways that your cells can go wrong becomes quite unique. And so, in fact, what we've seen is that cancer is probably thousands of diseases. And as we get better at drug treatments, we need to tailor those treatments towards each individual person with their own individual disease. The next decade is going to be about how do you find these targets for each individual person? And that's where all the cutting-edge technology comes in. That is a really big deal. So, in the 80s, everyone was focused on a silver bullet that would cure cancer. And I think as we've understood through technology and experience how complicated cancer really is, I think that what we are now seeing is that if we can target parts of the cancer at a time with a tolerable treatment, I think what we can realistically hope for is not one silver bullet to cure everybody, but multiple different sequences of tolerable treatment so that people can live a decent quality of life. I think we accept other diseases as chronic that we can't cure. Heart disease, diabetes, high blood pressure, these are not curable phenomenon. To set the bar for cancer to be curable is a high achievement. So I think for the short term, at least, if we can make it a tolerable disease with tolerable treatments, that's very successful. Historically, we were using toxins, basically poisonous drugs. And although they did have a cost associated with them, very quickly when they'd come off patent, the cost would go down quite a lot. And so run-of-the-mill standard intravenous chemotherapy that we're all familiar with is well-controlled poisons. And they are very effective in certain cases and certain situations. And it is still fundamental to what we do. And they have become very inexpensive. But it's at the cost of side effects quite often, and also how those side effects can really impact on people, and that actually has economic disincentives as well. So if you're feeling very sick, you're not going to work, you're not contributing to society in the same way, you're not paying your taxes because you're unwell, and so on. So this recent era of targeted therapy has changed drug development, and so it's actually a much more narrow focus. So pharmaceutical companies have to develop a lot more drugs, and more of them will fail. So when you have, for example, 5,000 drugs that look interesting for a pharmaceutical company, really probably only 100 of those end up in human testing, and maybe only 10 ever make it to market. So the actual cost is higher than just making a generic run-of-the-mill poison. So that is translated to more expensive drugs. No question, targeted therapy on the whole is more expensive. On the other hand, if you're able to give somebody an easier to tolerate drug where they live longer, then they are still staying at work. They're contributing, they're participating in their family life, they're paying their taxes, they're living better, and they're staying out of hospital longer. So it's hard to make an economic argument because these drugs are so expensive. On the other hand, it depends on which pocket you're pulling money out of. Well, I think it's an important conversation because the more drugs that are developed, the more expensive they are. And we, as a society, can't afford to just bring in all targeted therapies for everybody. And so we recognize the value of these targeted therapies. We recognize their expensive commodity. What we need to focus on is who to give those treatments to. And there's no doubt that they're valuable. But we can't just apply them broadly across a population, and I think that's an important conversation to recognize also that people always want the newest and the best and the most expensive, but quite practically that's not necessarily the best treatment for them, and we can't afford that as a society.